Welcome to This Explainer. Today, we're diving into a seriously unexpected intersection. We're looking at how a 19th century homeopathic philosophy about the mind actually lines up with the incredibly rigid, high-stakes safety protocols of modern psychiatry. So, if you've ever wondered how holistic care survives and actually operates inside a modern psychiatric emergency, well, you're in exactly the right place.
Okay, let's take a quick look at today's roadmap. We'll be covering mind and body connected, reconstructing the medical totality, the 4 clinical groups, humane conduct and ethics, and we'll wrap up with psychiatric crisis and safety. Let's jump right into section 1, mind and body connected.
Think about just how revolutionary this idea was back in the 19th century. Samuel Hahnemann didn't see mental illness as some disembodied, isolated spiritual defect. No, he saw it as a physical disease of the whole living organism. In his classical text, the Organon, he called these one-sided diseases. Basically, this means the mental and emotional symptoms have become so dominant, so overpowering, that the physical symptoms just kind of fade right into the background. The disease is still corporeal, it's still in the body, but it's only showing us this one major side.
It's actually amazing how well this historical framework maps onto our modern understanding. Classically, these were viewed as internal, deep-seated chronic diseases manifesting through the mind. Fast forward to today, and we call that the biopsychosocial model, which is this complex mix of neurobiology, trauma, and social context. What's really beautiful here is that both of these models agree on one massive point. We need to drop the stigmatizing labels, treat the whole person experiencing the distress, and focus on the real functional impact it's having on their life.
Moving on to section 2, reconstructing the medical totality. So, how do you actually treat a patient when their physical symptoms have seemingly just vanished? Well, you follow a really systematic approach. It's kind of like being a detective. First, you map out the current mental state, documenting the exact moods, anxieties, or delusions. Then, you trace the history. You're asking what severe physical illness happened right before this mental shift. Next, you observe them during temporary remissions or lucid intervals to ask about residual physical aches. And finally, you synthesize all that past and present data to treat the whole picture. But hold on, before any dynamic treatment begins, we have to ask a critical, literally life-saving question. Is what we are looking at truly a primary mental illness, or is it a medical mimic? This is absolutely crucial. You cannot just blindly treat mental symptoms. A sudden presentation of severe confusion or psychosis might not be a psychiatric break at all. It could be encephalitis, it could be a severe thyroid storm known as thyrotoxicosis, drug withdrawal, or even a total metabolic collapse. Assuming every single psychiatric symptom is purely psychological is a massive, dangerous, and honestly, potentially fatal error. To get that diagnostic clarity and completely rule out those dangerous mimics, modern practice absolutely mandates a structured mental state examination, or MSE. This means rigorously evaluating everything from a person's appearance, behavior, and speech to their subjective mood, their thought content, and their baseline cognition. It takes a really vague complaint like, "My mind is just not right," and translates it into hard, highly specific clinical data.
All right, that brings us to section 3, the 4 clinical groups.
Historically, these cases fall into 4 distinct groups, and it is fascinating how perfectly they align with modern management pathways. For physical origin cases, where a physical pathology transforms into mental symptoms, we reconstruct the case totality. For acute excitation, think sudden mania or delirium triggered by a shock, we jump straight to acute stabilization. Then we have doubtful origins, where a clinician might try supportive counseling first just to see if it's emotional stress rather than a deep somatic disease. And finally, emotionally maintained diseases driven by things like prolonged grief, which today rely heavily on trauma-informed psychotherapy and social support.
Next up is section 4, humane conduct and ethics.
The historical context on this is wild. Back when 19th century asylums were actively using chains, mockery, and corporal punishment, Hahnemann fiercely opposed the violence. He demanded dignified, non-punitive care. And that perfectly matches our modern directive for handling delusions. Acknowledge the emotional suffering beneath the delusion without validating falsehoods. You don't aggressively argue patience into reality, because that just ruptures trust. Instead, you stay calm, respectful, and entirely focused on safety. But here is where the eras wildly clash. Historically, doctors genuinely thought it was a brilliant kindness to secretly slip medicine into a violent, uncooperative patient's drink to avoid forcing them. Back then, covert administration was seen as paternalistic care. Today, absolutely no way. That is a massive ethical and legal violation. Modern practice operates strictly on informed consent, evaluating mental capacity, and working transparently within lawful frameworks. So tricking your patient is, thankfully, no longer on the table.
And Matt leads us to our final and most critical segment, Section 5, Psychiatric Crisis and Safety. Practitioners are taught that they must directly execute 4 pillars of risk screening. First, you have to ask directly about suicidal ideation and plans. And a really crucial takeaway here, asking directly does not plant the idea in a patient's mind. Rather, it provides a vital, life-saving opportunity for intervention. You also absolutely must screen for harm to others, especially command hallucinations, check for severe self-neglect, and identify any protective factors like family support. Consider this high-risk crisis scenario taken directly from the source's interview lab. A 24-year-old student says, "The voices are screaming at me to jump tonight. I have to do it to stop the lasers." A command hallucination combined with a specific lethal plan is an immediate, life-threatening red flag. It requires instant, decisive action. In severe crises, like the one we just looked at, outpatient homeopathic prescribing completely stops. Let me repeat that. It stops. This uncompromising emergency transfer protocol takes absolute precedence. You never leave the patient unattended. You secure the physical environment from sharp objects, you immediately contact emergency medical services, and you execute a direct, transparent clinical handover to the receiving psychiatric team. There is literally zero room for hesitation when it comes to patient safety. As medical ethics continue to evolve, it leaves us with a really provocative question to ponder. How can practitioners effectively balance the deep, individualized empathy of holistic care with the rigid, absolute demands of modern psychiatric safety? It's a delicate, fascinating evolution that requires both historical appreciation and uncompromising modern clinical rigor. Thanks so much for joining me for this explainer. Stay curious, and I'll catch you next time.